Now we're going to move on to the other thing that a lot of patients don't know about, and even a lot of physicians don't know about, which is bariatric endoscopy. And bariatric endoscopy means there's no incision. You go home the same day. There's no cuts on the abdomen. They're done through your mouth. So most people have heard of an upper endoscopy or a colonoscopy. So similar to that, in which these devices are done by upper endoscopy. So you're asleep, you don't feel or remember anything. But importantly, there's no surgical incisions or hospital downtime and quicker recovery. So it's sort of that mini step before patients will go to sort of a surgical intervention. And the reason these came about was, although there are many patients that are eligible that meet criteria for bariatric surgery, we found that that number of patients that are actually signing up for those procedures is not going up every single year, even though these patients would have reduction in their diabetes, high blood pressure, cholesterol, fatty liver, with the amount of weight loss they'd be able to achieve. I think there's A, stigma. I think there's B, a lot of patients that are concerned with having an elective surgery for something they feel like they should be able to do themselves. And there's sort of the bias that surrounds bariatric surgery, feeling like they're taking an easy way out, which we always sort of get rid of that bias right off front, right? And so these were sort of that middle ground that were sort of came up to help patients get a little bit more than medication, but a little bit less than surgery, but sort of that intermediate to sort of help jumpstart people. So this is broken down into sort of space occupying. So we'll talk about sort of intragastric balloons, suturing devices, which we sort of suture the inside of the stomach to make it smaller. We won't talk a lot about sort of bypass devices because there are some of those, most of those are still sort of just experimental, and also some of these other devices. So we'll talk about the ones that sort of we do mostly, especially here in the US. So the balloon itself, initially approved in 85, and then there had some issues with it sort of going and migrating. So they got rid of them and went back to the drawing board and said, all right, let's do this a little bit better. Then they came back in 2004, then FDA abroad. And then in 2015, these balloons came to the US. And so the indication for these is someone that has class 1 or 2 obesity, which means a BMI of greater than 30 to 40. They're kept in place for 6 months and then removed, both endoscopically. So it takes about 10 minutes to insert, and then it's removed. Also takes about 10 minutes that you're asleep and you wake up and you go home. The way this balloon works is a space occupying, meaning it helps with patients to physically be able to reduce their portion size. So we're teaching patients about reducing portion size, but this balloon is sort of in the way. So you're not able to eat as much as you typically would. And during that period, I tell patients the hard work is those 6 months that balloon's in place, because you are learning every single day to listen to your body. You're retraining your body to hear those triggers that have told you, I am full. I am satiated. And that's because you physically don't feel great if you eat beyond that at this point. And that sends that signal to the brain to tell yourself, you know what? I think the next time I was probably full at about 3 bites last time. I think that's enough for me. That's the goal, is to get people to re-engage listening to your body. And we call it mindfulness. It's being mindful of how you feel when you're eating and being more in tune with your body and slowing down a bit. And so just to show you how that works a bit here. So we are inserting the balloon into the stomach here, and then we fill it with about 500 cc's of fluid, take the scope out, leave it in place. That way, when you're eating, it's taking up space in your stomach. So you're not able to eat as much. And I'm teaching you that you can feel satiated with smaller portion sizes. We come back in 6 months, we poke a little needle in there, and we're able to suction all of that volume out sort of endoscopically and making that balloon real small again. And then we're able to take it out, and then you're all done. Usually patients have lost, the studies will say at least 10% of total body weight loss, but typically we see a lot more. And that's because we make sure patients are following up and coming back in to be able to understand what is happening, and sort of teaching them those same things we talked about before. Nutrition labels, serving size, thinking about how to eat when you go out, listening to how you feel when you have particular foods, listening to your body. And patients that we see will often continue to lose weight even when the balloon is out, because they have instituted and they've sort of really bought into sort of a new way of living and a new way of sort of thinking about food and considering intake. And this is what it looks like sort of in an actual patient. This is an actual stomach with a balloon that's sort of placed inside. And so if you can see, it's sort of taking up a large portion of the stomach here. And that's just the scope itself, just sort of looking back on itself to be able to see what the balloon looks like. The reshaped balloon is a balloon that has two different balloons, and the idea was that it would reduce sort of migration, which was a problem sort of years ago. But the idea was that it would cause less symptoms in patients. The next balloon is the obalone balloon, and that was like it's a gas-filled balloon. So the problem with the volume-filled balloon with the liquid is it feels really heavy. It can cause some nausea and vomiting. People can feel pretty uncomfortable. So the idea was, why don't we create one filled with gas so it's lighter, so people don't feel as heavy. And so this is that one. So patients would swallow a balloon that's attached to a little cord that's there. It goes down into their through the esophagus and into the stomach there. And then we sort of have to make sure by using sort of another device that sort of it's in that area. And then we're able to fill it. Folks, we use sort of an imaging device to make sure it's actually in the stomach and not anywhere else. And then sort of fill it with gas, right? And then we sort of slowly would show people over time, see how they're doing, to see how satiated they feel, to monitor those symptoms. Once they feel okay with that one, then over time they'd be able to add an additional balloon, right? The upside for some people is they didn't have to have endoscopy to place the balloon, but some you will have to have it removed, right? And so patients, and so you're able to sort of slowly sort of increase how many balloons patients have over time. And typically you can get up to about 3, which each balloon having a volume of about 250 cc's. And so this balloon will cause patients to have definitely less symptoms than the saline filled balloon. But it takes a little bit longer. And also patients don't lose as much weight as they would with the other balloon. But it is very much better tolerated there. So as you can see, what it would sort of look like with sort of 3 balloons in place, still coming back at that 6-month period to come back in and have those balloons sort of removed, right? And it's taking that air out and sort of reducing the size of those balloons and being able to remove them and sort of endoscopically. Also at the same time, checking that stomach to make sure nothing is abnormal that's happening there. And so when we compare sort of the data of how much people are actually losing, they have the control versus the actual procedure group. And what you'll find is definitely always more in the active group. And like we talked about, the Orbera, which is the first balloon with the fluid, is the one that got the most weight loss. So typically at least 10% total body weight loss. But like I said, in clinical practice, we always see more. Contraindications to these balloons: if a patient has had gastric surgery in the past, if they have a really big hiatal hernia, a coagulation disorder, meaning a bleeding disorder, potentially a bleeding disease because we don't want to irritate that, pregnancy, alcoholism or drug addiction, or severe liver disease because that can cause varices, and then we can irritate those with that balloon moving around and cause bleeding. And sort of relative contraindications of things we think about are things like esophagitis, so making sure that's treated first. Crohn's disease, making sure patients are well controlled with their Crohn's. Chronic NSAID use, and that's because NSAIDs can cause people to have ulcers, and that can irritate things, make people have bleeding. And then uncontrolled psychiatric illnesses like binge eating, nighttime eating, bulimia, anorexia, these types of things as well. So making sure those things are well controlled before proceeding. And then adverse events, we alluded to a little bit earlier. When you have that saline-filled balloon, patients tend to have, when we talk about sort of before they get it, that first week you will have a lot of nausea, maybe some vomiting and some abdominal discomfort. You sort of just feel that sort of balloon sloshing around. And sort of the biggest risk is having to have that removed early because they just can't tolerate it. So we make sure we talk about that in detail. So if it's somebody that has baseline bloating, abdominal pain, these are things, it's not probably a procedure for you because you're going to feel pretty miserable. Let's see, hyperinflation, which means the balloon continues to fill with air, even though we're not putting anything in there. And that tends to happen if people sort of leave the balloon in place for a longer period of time. There was a patient that presented from a different country that left the balloon in place for over a year and was having with a lot of abdominal pain. And that's because she'd had hyperinflation. And the reason being is the balloon, that's why the balloons are made to be removed in 6 months. Acute pancreatitis is another complication. And then the death rate, right? And so what was a big deal a couple of years ago was there was like, oh my goodness, there's all of these deaths from balloons. But when you look at the total number of balloons being placed worldwide versus the number of deaths, it was 18. And they did not disclose that, but when you looked into more detail, there was a person who had a car accident. It just happened to have a balloon. The balloon did not cause a car accident. There was one person who had a heart attack. The balloon didn't cause the heart attack. So there are many other reasons, but they have to be reported because they had a balloon in place at the time of death. Limitations to this. They are unable to provide sort of long-term substantial weight loss unless the patient really buys in and continues to stick with the plan we've instituted. And then cost, because most insurers don't cover it. Although this past week I've had a patient that was able to get it approved by their insurer. So hopefully we're moving that needle so that they're able to get some of these things covered. The transpyloric shuttle is another sort of
While the patient is
sorry, that was loud. In which you're able to basically put a little device into the abdomen, that sort of into the stomach, that really bobs back and forth in the stomach, that sort of creates sort of a bowel obstruction, which we don't typically like as GI doctors. But this one is sort of slowly sort of keeping food into the stomach for a longer period of time so that people feel full for a longer period of time. So it increases sort of decreases that gastric emptying. So yeah, if you can imagine, so that you eat a meal, it's not able to leave the stomach because this little thing that we're inserting is sort of closing off the way that it would exit to get out of the stomach, which is going into the small bowel. So if you continue to have food in your stomach that is sort of stretching those stomach and those receptors, that you don't get that signal that makes you feel actually hungry. And so you're thereby sort of reducing caloric intake by eating less and not having that urge to sort of snack and that sort of thing. And so as you can see, it sort of moves sort of back and forth. And as it moves into that area, peristaltic waves will sort of move it back and forth. And as the stomach is sort of moving, you'll notice that most of that stuff is sort of sitting in the stomach. The bulb will sort of move out a little bit and then allow a little bit more. This is sort of just all happening sort of throughout the day without you even sort of having to be aware of it. And so that's sort of how that one works. And then the endoscopic sleeve gastroplasty. This is one that was sought to sort of mimic the surgical sleeve, but without cutting the actual stomach off here.
the first
And
row.
what we see here is what we do is instead of there being a balloon on the inside of the stomach, there's a suturing device. And what we're doing is taking sort of several bites throughout the stomach, and with the goal of being able to sort of cinch that stomach, make it much smaller and sort of reduce that size, right? And sort of zipping it up. And so being able to sort of try to make a smaller, more tubular shaped stomach by the time we get done, that sort of reduce that sort of inside anatomy to about 30% of the size that it typically was before. And so as you can imagine, with a reduced sort of volume, you're eating less. The other ways in which that is working is typically when you eat, you're also reducing patients sort of their ability to empty. So things are sitting in the stomach for a longer period of time. So you have delayed gastric emptying. And you're also sort of since having food sitting around for a longer period of time, you're also feeling satiated for longer. So you're thereby eating less as well. We also sort of use ghrelin to our advantage because we're having food that's sort of sitting in that area. So it's sending that signal to the brain that says they don't need to send you that signal to make you feel hungry again. And then, so this is what this looks like sort of in a real patient. So on the left is sort of a normal sort of large stomach here with air in it, sort of what it normally looks like. And then this is the device itself, but sort of how you can see how small that stomach is made sort of with those suturing devices. And again, going home the same day, no incisions, and sort of having those results sort of right away. And so the data for the endoscopic sleeve, so now there's been like 5-year data to sort of help us to be able to understand what happens over time. And so initially, we definitely see over 75% of patients that have at least 10% of their total body weight loss with this procedure. And that corresponded to about 18.1 kilograms. And so about a little less than 40 pounds, right? And then at 5 years, the question with these procedures is how durable are they? Are they as durable as surgical procedures, which means do you still continue to have success 5 years out, or do those success sort of wane? And what we found is about the same amount, of weight loss that we see sustained at those 5 years. So over 69% of patients still with over 10% of their total body weight loss at that time, averaging out at about 15% of that total body weight loss, 14 to 15%. And that's really the goal, to make sure people are able to sustain this weight loss, right? And so some of the adverse events you can see are abdominal pain, typically very minimum. You can get a perigastric fluid collection, but rare. There can be GI bleeding. As I tell my patients, we are causing bleeding by sort of nicking the stomach sort of over and over and over again with sort of a needle. So we're able to usually treat it if we see it while in there. And then on rare causes, sort of a perforation, but also very rare. Another device called Pose 2. It's not approved here in the US, but can be seen sort of abroad. And it's sort of similar, but it's a sort of application device that does full body thickness. And it's sort of a different sort of procedure that's a little bit different than the endoscopic sleeve, but it's sort of the same idea, which is invaginating the stomach as you see it, sort of bringing it towards you and placing these little sort of baskets to sort of create the stomach and pull it in to make it a lot smaller. So it's a little bit more technical and complicated, and it requires sort of two people. One person is holding one of the scopes and one person holding the actual device. But when you get done, you sort of have a similar sort of approach to being able to shrink the size of the stomach and sort of reduce sort of how much patients are intaking. All right, so that's what it looks like when it gets done. So a much smaller sort of shortened stomach as well. In the data there's been some 2-year data on many patients. And this is from Madrid, Spain, where one of the experts does a lot of these procedures. And what he was able to find is after about 24 months, the patients were able to keep off about 15% of their total body weight loss. And these patients were mostly, mixed male and female. They were starting at about a BMI of 37, and they didn't have any serious complications, and most of them had a lot of follow-up. And so this is just showing sort of the safety and efficacy of these procedures. Adverse events. This one, the big one is sore throat because of how large the device is. Some abdominal pain, nausea, vomiting, some bleeding, rare complications of perforation or pneumothorax. I think they've had one complication of an abscess that was resolved without surgery. So rare complications as if you can have with any procedure, but overall safer and of course going home the same day. And now we talk a little bit about the thing that we know more about, which is sort of bariatric surgery. And the thing I like to talk about here is, these have gotten so much safer over the years. They're laparoscopic, so usually just done through some ports. And they're fairly quick now. So it's easy as sort of taking out a gallbladder at this point. And so, but the ones we know a lot about are the Roux-en-Y gastric bypass, in which you're actually bypassing a portion of your small bowel. Used less frequently now is the lap band, so that's not used a lot. The gastric sleeve, where you're cutting off sort of a large part of the body of the stomach. And the vertical banded gastroplasty also not used a whole lot anymore. So mostly the sleeve gastrectomy and the Roux-en-Y gastric bypass are used mostly. So this is a study that showed us a little bit of the data, like we talked about before, of sort of how effective and how much weight loss patients can expect with bariatric procedures and bariatric surgery. And so you're going to see a difference in sort of more weight loss with bariatric surgeries versus an endoscopic procedure. And so if there's a patient that needs a larger degree of weight loss, we will often talk about sort of where their surgery is a better option for them, or how they feel about sort of what their trajectory has been in the past, what we think is going to be helpful, what they're going to be able to achieve, how difficult weight loss has been to achieve for them over the years, and sort of what their history is going to be that gives us an idea of sort of how difficult things are going to be. And so at 1 year, we'll see in this left column here, the sleeve gastrectomy versus the Roux-en-Y gastric bypass. You'll see that patients' total weight loss will be the sleeve at 25.2, and then the Roux-en-Y gastric bypass at about 31.2. At 3 years, you sort of are able to sustain about 21% with the sleeve gastrectomy, and with the Roux-en-Y gastric bypass, about 29%, and then sustainable at 5 years with about 18.8% with the sleeve gastrectomy, and the Roux-en-Y gastric bypass at 25.5%. And so, as you can see, less than we saw with the endoscopic procedures, but well tolerated and sort of been able to sort of sustain over that 5-year period. They do talk about the the gastric band, but those are actually, we saw less on why people don't use it really as much anymore. So we'll just talk about the two main ones, which are the sleeve gastrectomy and the Roux-en-Y gastric bypass. And so when we bring all of this together, right, we've talked about a lot today. The one thing I want people to take home is that excess weight is complicated. So giving yourself a little bit of grace, giving your family members a little bit of grace, being able to understand that it's not just sort of how much we're eating and how much we're moving, understanding that it is a chronic disease that is relapsing, that is multifactorial, that there's so many factors, right? But also there are many treatment modalities that are now available too, right? And so starting with the basics with understanding food, understanding nutrition, understanding sort of portion control and portion sizes, understanding sort of dietary intake, not beating yourself up about sort of eating too little and sort of caloric intake, and understanding sort of those are going to affect each person's body very differently. Um, and sort of trying to change those ratios of sort of what we're eating, with sort of reducing a lot of that processed food and those sugary sweetened beverages and processed foods, while increasing those things that are going to be higher in fiber, those fruits, vegetables, whole grains, beans, nuts, and also those that water intake. Getting people to just get some activity, just to get moving, but recognizing that you can't outrun, right, those dietary habits, thinking about those underlying medical conditions that can cause patients to have symptoms. So making sure those things are kept into account and sort of considered. Considering anti-obesity medications and sort of not being sort of put into a bucket and saying, oh no, I can't use those. Thinking about those and determining what's right for each patient, because they may not be right for everyone, but determining which one may be right for each particular patient. Not forgetting those endoscopic bariatric procedures as sort of that intermediate for patients that sort of don't want surgery, but they need a little bit something more to sort of help them in their journey. And then always remembering those surgical options, and being at a bariatric center of excellence is an also thing to make people feel a little bit more comfortable, but knowing that this is something that is lifelong, something that we have to work on forever because we know it's chronic and relapsing, and knowing that it's really a lifestyle change that we try to get patients to sort of consider, instead of thinking that it's something that's a fad, it's something they can just knock off of the list and be done with it. And so that is sort of, I think that is it here. So yes, that is it. So I think now we will open to questions.